Great, there we are. Perfect. So my name is Mahim Jain, and today both myself and Dr. Sadowski will be talking about our experiences in managing bone health for patients with AFM. I'm a clinical geneticist, and my role on the team is in the medication management and providing medication to our patients who need treatment for osteoporosis. So in the first half of my section, I'm going to go over, give a general overview of bone mineral density maintenance, the loss in AFM, and then treatment options. I will then go over some clinical case presentations. So on this slide, I'm stating the problems and the overall clinical health goal. We know that our patients with AFM are at risk of developing secondary loss in bone mineral density related to factors that have been mentioned in earlier sessions, including the loss of mobility and the flaccidity we see in the condition. In our experience, this bone loss tends to be rapid, primarily in our patients with the more severe presentation, and can have associated hypercalcemia. This bone loss can increase the risk for fractures. And, at this time, there's limited evidence that's on the best treatments that would be AFM specific. Really, we're using our knowledge for other conditions to help guide the treatment for AFM. The overall clinical goal is one to prevent fractures. When I talk to patients and their families, I highlight the fact that in the recovery from AFM, physical therapy, continued improvement with a multidisciplinary team is important. And a fracture can really affect the trajectory of improvement. So our goal with treating this is to try to prevent fractures. So to review how bone density is managed in the body. We often think that bone is something that's inorganic and there to really protect all the important stuff in the body. The reality is that bone actually is under a regulation for many different types of cells. We know that osteoblasts build bone, and osteoclasts are important for the breakdown or the resorption of bone. Osteocytes that are located within the bone also are important for managing the interplay between the osteoblast and the osteoclast. For all of us, there's bone building and breakdown occurring, throughout our lifetime. Now, in AFM, we have a mechanical unloading of bone. So what we can see is that we know that weight bearing is important for maintaining bone density. We know that muscle strengthening and activities that where the muscle has tone and with movement is also important for bone density. In AFM, we have the loss of both of these. So, inferring from what we see in other conditions where we see loss of weight bearing and mechanical unloading, we know that all three of the cell types in bone can be affected. This includes osteoblasts that build bone, and in the early stages, they become overactive, and eventually there's been some data to suggest that they reduce in number and actually will not survive. Osteoclasts, the cells important for the breakdown of bone, become overactivated, and this tends to be have a relatively rapid onset. And then the osteocyte, the cell that's within bone, there is evidence that abnormal signaling can occur. And this is also felt to have a fast onset. So looking at our osteoblast and osteoclast balance, what we see is that with the onset of AFM, we see that osteoclast activity increases greatly, and that leads to more bone breakdown. The osteoblast also has an increase in activity for a period of time, but that's felt to eventually lead to an overall decrease in a longer time period. It's also been demonstrated that with mechanical unloading, osteocytes, the cells within bone, have changes in the factors that they release, such as rank ligand, sclerostin, DKK1, and other signaling molecules within bone. So what we observe is that there's a reduction in bone density that tends to have a fast onset, and we have seen an increased risk of fractures for some of our patients with AFM. Also, within about the first 3 months of onset of AFM, for a large percentage of our patients, we do see hypercalcemia. The bone is breaking down, calcium is being released. And for some of our patients, there's been an association of the development of kidney stones basically from the excess calcium that's being released. Now, there are several potential therapies that do exist for the treatment of bone mineral density. Our go-to medication are bisphosphonates, either pamidronate or zoledronate. Both of these medications work on the osteoclast, the cell that breaks bone down, and reduces the function of the cell. They're also tend to be well-tolerated medications, and there's a long experience in using them in pediatric populations. Like a lot of medicines that work on bone, there is some diminished return, meaning that we can only use this medication for 3 to 5 year periods before we start seeing a loss of effect of that treatment. I'm briefly going to touch on 4 other classes of medication that may be used to treat bone density. However, there's limited experience in a pediatric population, and thus they're not really one of our go-to medications. Denosumab is a rank ligand inhibitor and works very similarly to bisphosphonates in that it stops the osteoclast activity. But again, it's not a medication we typically use in children. We also have 2 medications that help build bone. These are variations of parathyroid hormone and an anti-sclerostin antibody that exists. And there is the potential to use these types of medicine in later stages when we need to build more bone rather than stop the breakdown of bone. And an emerging therapy is anti-TGF-beta antibodies that are felt to have a mixed response or a mixed effect on bone, both building the bone and stopping the breakdown. And there's the potential, there's hope that this treatment may be beneficial to a broad class of patients. However, if we are targeting the TGF-beta pathway, there's always the risk that we may be targeting, other organs, other parts of the body where the TGF-beta pathway is important. So I'm going to move on to a couple of clinical presentations. And I'm going to say that, preface everything by saying that we have limited experience on the treatment of low bone density in AFM. We're going to need longitudinal information over time, and we're going to need kind of outcome measures, things like fractures, changes in bone density. Our treatment protocol includes mostly bisphosphonates, either pamidronate or zoledronate. And today, the 3 patients I'm presenting were started on pamidronate, where we have a goal treatment of about 4 milligrams per kilogram per year. So our first patient is an 8-year-old male, had onset in late 2018. He had a severe presentation. While admitted to the hospital, he was noted to have high calcium levels at 2 months of age and was started on bisphosphonates at that time for the high calcium. This again recurred at 3 months of age, and he was given more treatments with pamidronate. I've been following him for about 18 months, and he's had an improvement in strength and mobility, now walking with the gait trainer. We've been providing him pomidronate therapy over these 18 months, and he has not had a recognized fracture. I'm going to show some tables that highlight the bone density. We look at bone density in several areas of the body, including the lower back and both of the the lower extremities, as well as the total body. I want to highlight that this patient has received near the treatment goal that we've set up for him. And what we've seen is that he does continue to have some small reductions in bone density. However, with his clinical improvement in mobility, as well as the pomidronate therapy, his bone densities have remained relatively stable. Our second patient is a 4-year-old who had onset of a severe presentation. Her course also included high calcium levels at 3 months of age, and pomidronate was started at that time for controlling the high calcium. We've been following her for the past 18 months, and she has not had significant improvements in mobility. And I know that's continuing to be treated. And we've been providing her pomidronate over the course of the 18 months. For her, we are at about 3 milligrams per kilogram per year, which is a little lower than the gold treatment dose. She also has a severe presentation with slower improvement than our first patient. And what we're seeing here is that there are significant reductions in bone density throughout, notably in the distal femurs, which are a measurement which we see bone densities reduce when individuals are not ambulatory. Now, our third patient is a 2-year-old male, again with an onset in late 2018. He had high calcium levels in his blood, similar to the first 2 patients, and that was noted about 3 months after the diagnosis of AFM. No bisphosphonates were provided at that time, and this self-resolved. He's had improvements in his mobility, and we've discussed treatment with pomidronate for this patient, and the family's decided to wait for the time being, and we've not started treatment. And looking at his bone densities, what we do observe, again, is that there are reductions. What we see, again, is that the distal femur tends to be an area that's significantly involved. The reality is that while pomidronate therapy would be a possible way for us to increase his bone density, at this time, we have elected to just follow clinically and may decide to start treatment at a future time. So to summarize the cases I presented, limited data exists, and really we're going to need to collect more longitudinal information to really show and demonstrate if there is a clear benefit to these treatments. Bisphosphonates have been used in a handful of children. The treatment appears well tolerated. We haven't seen any new side effects or anything that has caused somebody to start the medicine and have to stop. Disease severity or our severe patients tend to have what appears to be greater loss in bone density and a greater risk of osteoporosis. I'm going to turn things over to Dr. Sadowski for her part of the talk to review the cohort at Kennedy Creek.
Hi, thank you, Mahim. I am going to add some data to your wonderful presentation about bone health in children with spinal cord injury. It is data that we collected from a cohort of 73 children with AFM that we've seen in the last decade at Kennedy Krieger. Out of those 73, 33 of them underwent DEXA scanning to identify low bone mass, and 78% of them were diagnosed as having low bone mass, or other, how we call it in other ways, osteoporosis. Out of the 73 children, 19 of them had fractures. And those 19 fractures occurred in 11 children, 9 in the arms and 10 in the legs, but only 1 of them in a child that was walking. What we found is that bone density in the lower limbs and the distal femur was associated with ambulatory status, meaning that children that were walking had better bone density. Bone mass also correlated with lean muscle mass, and the lean muscle mass correlated with functional performance as assessed by the physical abilities and mobility scale, although it did not necessarily correlate with muscle strength. Why is it important to know that bone mass correlates with muscle mass and with physical performance? Is because we know we can restore muscle mass. I wanted to thank my whole crew here. We have been very fortunate to be part of the rehabilitative care of a dozen of families with AFM, nurses, physicians, occupational, physical, speech therapists, social workers, case managers. Specific thanks to Janet Dean, to Carlos, of course, to Michelle Malacosta, Natalie Curley, Shannon Inches, and Anna Schneider. Thank you. Most of all, thank you to our kiddos and their parents that put up with us.